Good morning, colleagues. Today we address the single most critical intervention in modern medicine: hand hygiene. Far from being a simple routine task, hand hygiene is a biological imperative, a precise engineering of the clinical environment to break the cycle of infection. As medical microbiologists, we understand that the hands of healthcare workers are the primary vectors for healthcare-associated infections, HAIs. This presentation will move beyond basic checklists to explore the systemic execution of infection prevention, from the microscopic flora on the skin to the complex behavioral algorithms required for hospital-wide compliance. Our journey begins in the mid-19th century. In 1846, Ignaz Semmelweis, a Hungarian physician, established the link between hand disinfection and patient safety. He observed that improper hand hygiene during delivery led to catastrophic outbreaks of puerperal fever. By instituting hand disinfection with chlorinated lime, he drastically reduced mortality. Simultaneously, in the United States, Oliver Wendell Holmes independently reached similar conclusions, establishing that hands were the root cause of transmission. These pioneers transformed hand hygiene from a personal habit into an international standard for patient survival. To engineer effective decontamination, we must differentiate between the two types of microbial inhabitants on the skin. Resident flora, such as Coagulase-negative Staphylococci and diphtheroids, reside deep in the stratum corneum. They are generally non-pathogenic and compete for nutrients to prevent the colonization of more dangerous organisms. In contrast, transient flora, including pathogens like MRSA, VRE, and E. coli, colonize the superficial skin layers. These organisms are easily acquired through patient contact and are the primary drivers of HAIs. While resident flora require vigorous scrubbing for removal, transient flora are highly amenable to routine hand washing or alcohol-based hand rubs. Transmission is a predictable 5-step cycle. It begins at Node 1, where organisms are shed from the patient's skin onto inanimate objects in the immediate surroundings. At Node 2, these organisms transfer to the healthcare worker's HCW hands during care. Crucially, at Node 3, we see that these pathogens can survive for significant periods. Acinetobacter lawfii can survive for 60 minutes, and Burkholderia cepacia for 30 minutes. If hand hygiene is omitted or inadequate, at Node 4, the cycle completes at Node 5, when the contaminated hand comes into contact with another patient. This is our critical intervention point. A single action here severs the entire vector. The WHO 5 moments approach provides an evidence-based framework for when hand hygiene is mandatory. We map the clinical interface into specific opportunities. Moment 1 occurs before touching a patient, while Moment 2 is required before clean or aseptic procedures, such as drawing blood. After exposure to body fluids, such as decanting a Eurobag, Moment 3 must be performed. Moment 4 follows patient contact, and Moment 5 is required even if only the patient's surroundings, like bed rails or medical equipment, were touched. Adhering to these 5 moments ensures that the patient zone remains protected from the healthcare zone. We utilize 3 primary agents in our arsenal. Plain soap works through mechanical action to remove dirt and loosely adherent transient flora, but it has minimal antimicrobial activity and no effect on resident flora. Chlorhexidine gluconate, CHG 4%, acts by disrupting cytoplasmic membranes and precipitating cellular contents. Its hallmark is its residual activity, offering a persistent synergistic effect with alcohol. Finally, alcohol-based hand rub, ABHR, is the gold standard for routine rounds. It denatures proteins with a 60 to 80% concentration, is rapidly germicidal, and offers superior skin tolerability compared to traditional soap. Efficacy is not just about the product, it is about biomechanical thoroughness. For hand rubbing, ABHR, a duration of 20 to 30 seconds is required, whereas hand washing, soap and water, requires 40 to 60 seconds. We follow a standardized 6 to 10 step technique to ensure no anatomical zones are missed. Key high-risk missed areas include the thumbs, the backs of the fingers, and the nail beds. Clinical imperatives also dictate that we avoid very hot water, which increases skin damage, and always dry hands thoroughly with single-use towels to prevent excoriation and bacterial colonization. Surgical antisepsis is a higher tier of decontamination. The goal is to eliminate transient flora completely and significantly reduce resident flora prior to an operation. The first scrub of the day should last 3 to 5 minutes, while subsequent scrubs can be reduced to 3 minutes. We progress in circular movements from the fingertips down to the elbow. Modern standards now recognize waterless surgical scrubs using 15 milliliters of ABHR as equally efficacious, offering greater skin acceptability and fewer adverse effects compared to traditional brush-based iodide solutions. To manage hygiene, we must measure it. Direct observation remains the gold standard, where trained personnel use standardized software or WHO forms to record opportunities in real time. However, we must account for the risk register of audit. The Hawthorne effect, observational bias, often causes HCWs to behave more compliantly when they know they are being watched. We mitigate this through careful auditor selection, rigorous training to minimize inter-observer variation, and randomized schedules that cover all shifts, including nights and weekends. Beyond measuring if a worker cleaned their hands, we must measure how well they did it. Microbiological quantitation can be achieved via the luminometer method, which measures adenosine triphosphate ATP levels. The light produced by the luciferase enzyme is directly proportional to the microbial load, quantified in relative light units, RLUs. For non-microbiological tracing, we use fluorescent tracers like GlowGerm, which under a UV light box reveal missed anatomical zones, providing an immediate and powerful visual demonstration of ineffective technique. The hand hygiene adherence rate, HHAR, is our ultimate metric for systemic accountability. It is calculated as the number of hand hygiene events divided by the total hand hygiene indications, multiplied by 100. The denominator, the indications, is determined by tracking every WHO 5-moment opportunity within a specific time frame. While some systems attempt to alternate this by measuring product volume, e.g., 3 milliliters per event, this lacks the ability to reveal moment-specific behavioral compliance, which is essential for identifying specific clinical gaps. Why does compliance fail? We analyze this through 3 pillars of breakdown. Human and hierarchical factors show that doctors historically demonstrate lower baseline compliance than nursing staff. Environmental constraints include busy weekday periods, night shift fatigue, and inaccessible dispensers located too far from the point of care. Finally, systemic failures, such as chronic understaffing, a lack of leadership role models, and the absence of reward-punish accountability systems, create an environment where non-compliance becomes the path of least resistance. Improving HHAR requires a synchronized multimodal strategy. This engine relies on 5 interconnected gears. System change to ensure product availability. Education and training via continuous sessions. Audit and feedback to provide non-punitive trend analysis to staff. And reminders at the point of care. The central gear is safety culture, establishing a blame-free environment driven by administrative commitment. Only when these gears turn together can we move from individual effort to systemic reliability. In conclusion, hand hygiene is a systemic shield. By applying biological precision in our choice of antiseptics, clinical execution in adhering to the WHO 5 moments, and systemic accountability through relentless measurement, we sever the epidemiological chain of transmission. When engineered correctly, hand hygiene breaks the path from reservoir to host, remaining our ultimate safeguard for patient survival. Thank you for your commitment to this vital mission. I am now open for your questions.